reason for that is that there is a dearth of good quality clinical evidence to guide our therapeutic decision making. So quite simply put, we don't really know an awful lot about what drugs to use and how to use them or when to use them. We do know quite a bit about other stuff, such as when and how to give a transfusion, so it's not complete lack of knowledge, but there's certainly room for improvement. And as I said, the two diseases that we're going to speak about are IMHA and INT in both dogs and cats. So IMHA, most common, as you all know, in young to middle-aged pure breeds. Cats, we know less about this disease than we do in dogs. It's a less common illness. But generally speaking, and I want you to all to think of Hamlet across the way, because Hamlet does have IMHA. Less than 6 years old, tick, male, tick, purebred, because Hamlet is undoubtedly 100% Maine Coon. But yeah, so he sort of fits that demographic. And we also know that, as with any type of immune-mediated disease, it can occur spontaneously, or IMHA can occur because there is some other underlying disease or drug therapy that has stimulated the immune system, and once stimulated, the immune system goes off on a tangent and starts attacking the body's own tissues, in this case, red cells. Interestingly, what we know about this disease in dogs versus cats, if you look at what's published, about 60 to 70% of canine IMHA is spontaneously occurring, or primary IMHA, or autoimmune IMHA. Whereas the opposite seems to be true in cats, whereas only 40% of feline cases of IMHA occur spontaneously. The rest are due to some underlying disease. Now, a word of caution, those figures probably are accurate in North America. They are probably accurate in Western Europe. They would be wildly, wildly inaccurate in the Mediterranean basin or other areas where diseases like leishmania are endemic. Because if you saw a dog with IMHA in, say, southern Spain, you would be looking for leishmania. If you saw a dog with IMHA in South Africa, you would be looking for babesia, no question. So this association between IMHA and whether it's primary or secondary has a strong geographical bias. So if you ever end up working in other areas of the world other than where we are now, your perception and the overall perception as to whether IMHA is primary or more usually secondary is going to change, and it's going to change depending on the prevalence of infectious disease in the country that you're working in. This is how I think of the immune system. So normal state of play, and this is, note the title of the slide, it's immune-mediated disease. This isn't specific to IMHA or immune-mediated thrombocytopenia. This is generic to all types of immune-mediated disease. And this is about how it occurs, okay? So usually the immune system exists in harmony with the body's own tissues. It has to be, otherwise we'd all die very young, okay? So specific to IMHA, here we've got a red blood cell and a white blood cell in harmony. They're getting on, okay? No problems. If something comes in then to upset that, and this can be a spontaneous, spontaneously occurring dysfunction of the immune system, or the immune system can be stimulated by some other disease or drug therapy, the immune system erupts, goes haywire. And as a consequence of that, starts producing what we term autoreactive white blood cells. By autoreactive, I mean these are cells that instead of fighting off foreign invaders, through a case of mistaken identity, start targeting the body's own tissues. In this case, it's the red blood cell, and they start attacking and destroying red blood cells. This diagram works for any type of immune-mediated disease. Instead of the red blood cell, substitute whatever organ is being targeted by the immune-mediated disease. It could be meningitis of unknown origin. It could be steroid-responsive meningitis and arthritis, immune-mediated polyarthritis, rheumatoid arthritis, inflammatory bowel disease, immune-mediated thrombocytopenia, immune-mediated neutropenia. It's all the same at a very basic level. So if you can, and that's what immune-mediated disease is, that's all it is. If you can understand that slide, then you understand how immune-mediated disease works. That's it, in a nutshell. So let's focus a bit more on IMHA and see how this works. So we've said that the immune system starts targeting the body's own red cells. So how does that translate into destruction of the red cells and anemia? And there are two ways in which this can work. So this is an autoreactive plasma cell, type of white blood cell that produces antibody. You see it's producing antibodies that are recognizing and attacking and binding onto red blood cell. Took me hours to make this, okay, so hope you appreciate it. And then what happens, if these antibodies are big enough, and there is a class of antibody called IgM, it's a very big antibody. And if we have lots of IgM in circulation, all that IgM is binding onto the red blood cell, what happens is that activates a series of proteins called complement. Basically, what happens is that complement forms something called a membrane attack complex. It's like a torpedo, and it just goes straight through the red cell membrane, boom, end of red cell. So with complete destruction of the red cell, this is the most serious, if you like, manifestation of IMHA, okay? These are the dogs that get very, very super acutely unwell, generally need multiple blood transfusions, and often don't make it. They will be peeing what looks to be blood, but it's actually just hemoglobin. They will be really, really jaundiced, and their serum will either look really dark orange or may actually look red. Okay, not sure if you guys can see this, but these are a series of hematocrit tubes, and they're taken from one dog at day 1, day 3, and day 6. This dog had, if you like, iatrogenic IMHA. We gave it IMHA, and we did it by giving it a mismatched red cell transfusion. Okay, so it had some other disease that required transfusion because it was significantly anemic, but it had it was transfused with red cells that were totally incompatible with it, and as a consequence, its own immune system attacked and destroyed those red cells. So this is day 3 post-transfusion, the middle 2 microhematocrit tubes. And you can see that this dog has a really bad intravascular hemolysis at this point. It's pissing, its urine's turned red, okay? Its serum is also red, and it's got a massive breakdown of red cells. This is typically what you see with intravascular hemolysis. This is the more aggressive form of IMHA. But there's another, if you like, equally very significant, but if you like, slightly gentler form of IMHA, and this is extravascular hemolysis. So here we have the same situation. We've got our autoreactive plasma cell, the angry plasma cell that's attacking, in this case, the body's own red cells. It's generating lots of antibodies, and those antibodies are binding onto the red cell. These antibodies are a slightly different class. You don't need to remember the name. The name's not significant, but for what it's worth, these are IgG. These are a smaller antibody. Okay? So they're not really big enough to attract complement. So we don't get this torpedo-like effect. Okay? Instead, these antibodies rely on interaction between macrophages that are generally in lymph nodes and spleens to affect the destruction of the red cells. So the antibody binds onto the red cell, but nothing much happens, and the red cell courses along the circulation with the antibody attached until it gets to a lymph node or the spleen. And at that point, the macrophage recognizes the antibody and binds onto it. Now, a macrophage at that point will do what macrophages do, and that is they try to engulf the red cell. And they either do that successfully in adios red cell, or they will just merely bite the red cell and take a chunk out of it. Now, red cells don't have a nucleus, they don't have genetic material, so they don't really do much in terms of growth and repair. But they do have a limited ability to repair defects in their membrane. So if the bite that the macrophage takes isn't quite big enough, then the red cell can actually repair itself. And it'll be smaller, okay? And because it's smaller, it loses its characteristic donut appearance, so it doesn't have a central pallor, okay? So these small red cells without a central pallor, they're called spherocytes. And they can continue along in the circulation, doing their job up to a point. But even though the red cell has affected a repair, that repair is always going to be temporary. It doesn't last very long. So these spherocytes have a short half-life. So they don't live as long as your average healthy red cell. And this extravascular hemolysis, in terms of how it manifests, is usually not as severe or as sudden a destruction of the red blood cells. So these patients may be jaundiced, but they're not going to be as jaundiced. They'll develop anemia for sure, but maybe not quite as quickly as the dogs with intravascular hemolysis. But I think as clinicians, we're very fond of giving things labels. We want to know that it's disease X or Y or Z. We want to know if it's in the setting of IMHA, is it intravascular hemolysis or is it extravascular hemolysis? And truthfully, it's not that simple. Every dog with IMHA will probably have elements of both intravascular and extravascular hemolysis. It's just some dogs polarize, and the same for cats, polarize to one end of the spectrum or the other. But in any given patient with IMHA, both forms are going to exist. It's just in some dogs and in some cats, one type tends to dominate the clinical picture. And what in a very roundabout way I'm trying to explain is that some dogs and cats can have a relatively slow onset of IMHA. Some dogs and cats can have a really fast onset of IMHA. Some dogs and cats can have an IMHA that's much, much more difficult to treat, okay? Other dogs and cats tend to respond better. And what mediates the severity of disease and response to treatment in a lot of patients is the type of immune response and which form of immune response dominates. Okay, so enough about the background. How are we going to diagnose it? Generally speaking, we look for three things. We look for an anemia that in most instances is regenerative. We can look for spherocytes, which are indirect markers of an immune response directed against the red cells. And then we can look for more direct markers of an immune response directed against the red cell. And by that I mean, we look to seek the presence of, or actually directly measure the numbers of antibodies directed in against the red cells. And we can do that through two things, looking at a slided glutination test or looking at a Coombs test. Remember this picture here, okay? Remember I said this dog didn't have IMHA that occurred naturally. We gave this dog IMHA by giving it a mismatched transfusion. So that dog, by the time day 3 came around, and certainly by the time day 6 came around, would have had all of the markers for IMHA, but it didn't have naturally occurring IMHA. We gave that to the dog. So if you recognize a dog you suspect has IMHA and it's very anemic, you're going to want to do a blood transfusion, for heaven's sake, make sure you've got an EDTA sample and a few blood smears set aside before you give it blood. Doesn't mean you need to wait for the results to come back before a blood transfusion is given, but you should really have those samples set aside. Once that blood goes into the dog, all of these can become positive, but they can be false positive. Same thing applies if you're going to give it steroids or other drugs to suppress its immune system. Have those samples standing by. You don't need to necessarily have the results back before you start treatment. But again, if the steroids or any other drug's going to work, what they're going to do is they're going to switch off that antibody production. They're going to stop the spherocytes being formed. They're going to potentially create false negative test results. So the blood samples that you need, and all you need is an EDTA and a few smears, have them and set them aside. before you do anything to treat the patient. Okay, so let's dial down on these things a little bit more. So we said that most cats and dogs with IMHA will have a regenerative anemia. Well, that's fine, but loads and loads and loads and loads of other diseases can result in regenerative anemia. So regenerative anemia in itself isn't at all specific for IMHA. Lots of other diseases can have regenerative anemia. But interestingly, again, if you look at Hamlet across the way, we've run 2 blood samples now, 4 days apart. Both went to IDEX, and on both of these samples, Hamlet has a non-regenerative anemia. And actually, this isn't at all uncommon, because up to 40% of cats with IMHA, up to 60% of cats with IMHA will have a non-regenerative anemia, whereas about 30% of dogs with IMHA will have a non-regenerative anemia at time of diagnosis. Now, there's a few reasons for that. One is, and we'll come on to talk about this later on, that the immune system, we classically think of it as targeting red cells in the circulation, the fully grown up red cells that have been released from the bone marrow. But there's no reason really why the immune system couldn't switch the focus of its attack to the immature red cells in the bone marrow. And sometimes that is exactly what happens. And you stop the production of red cells at source, so-called non-regenerative IMHA. Cats, and Hamlet is no exception, are prone to retroviral infections. We know that retroviral infections, which is FELV and FIV, can sometimes target the bone marrow and stop its ability to respond. And we've also got this thing called pre-regenerative anemia. And by pre-regenerative anemia, what I mean is if you have a very acute episode of bleeding or hemolysis, so an animal has suddenly developed a severe IMHA and become significantly anemic, the bone marrow needs time to respond. It takes about 3 to 5 days for the bone marrow progenitor cells, these cells that generate new red blood cells, to kick in and start doing exactly that. And it takes a while for those immature cells to develop within the bone marrow until they're released into the circulation. So even though the bone marrow gets stimulated very early on, it takes a while for these cells to mature sufficiently to be released into the circulation. So there's always a lag time between when the anemia starts and the bone marrow starts to compensate. And that's called a pre-regenerative phase. So if you have a dog or a cat that's become acutely anemic, you look at a blood smear and you think, well, that's non-regenerative. Always repeat it in a few days later, because a lot of the time you'll see that the regenerative response will start, it just takes a few days. So the next thing we talked about in terms of diagnosis is directly looking at evidence for an immune-mediated response or antibodies directed against the red cells. And there are 2 things we can do. One is a slide agglutination test, and the second thing is a Coombs test. And both of these things are looking for exactly the same thing. They just use slightly different techniques. And what they're looking for is antibodies directed against the red cell. Slide agglutination test we can do in-house. Coombs test we need to send to an external lab. Okay, slide agglutination test, many of you know how to do these. For those of you that don't, it's dead simple. Get a drop of patient blood, put it in a slide, hold a slide in your hand so it's warmed, put 4 drops of saline, swirl it all around. Normally, what you're going to see is just diluted blood. Okay, occasionally, if you've got lots of antibodies directed against the red cells, then what you're going to see is this. And these antibodies here in green, they cross-link between the red cells. You see how the antibodies are binding the red cells together? And if there's enough of them doing that, then the red cells are going to form grossly visible clumps, like paprika, okay? And you're going to see those clumps on your slide. If you see that, you know that the patient's got IMHA. But a lot of times, even if they do have IMHA, you're not going to see that because there aren't enough anti-red cell antibodies. And in that case, you've got to use a more sensitive test to diagnose the condition, and that's the Coombs test. Okay, so both things both tests, the slide agglutination test and the Coombs test, are looking for the same thing, which is anti-red cell antibody. The Coombs test is a more sensitive test at picking up the presence of anti-red cell antibody. We spoke a little bit about spherocytes as well. So we know that spherocytes are formed when you've got a so-called extravascular hemolysis and you've got your antibody directed against the red cell. The antibody binds onto the red cell, goes through the spleen or the lymph node, and macrophages take a chunk out of the red cell. And sometimes, if the bite isn't quite big enough, the red cell can repair itself and continue on. But it's smaller, it's shrunken, and it doesn't have its central pallor, and so it's a spherocyte. And these are hallmarks of IMHA. Now, other diseases can cause spherocytes to form as well. But those other diseases, which are hereditary spherocytosis in some dogs, zinc intoxication, onion toxicity as well, a disorder called microangiopathic IMHA, are all much, much less common. Okay, so by and large, spherocytes are a very, very strong indicator for the presence of IMHA. And you can see here, this is your typical red cell. So it's fairly big in comparison. It's got central pallor, okay? And then you've got these guys, which are small and don't have a central pallor. And those are your spherocytes, okay? Cat red blood cells are generally a bit smaller than dogs, and oftentimes naturally don't have a central pallor. So it's extremely difficult, and I would say impossible, to accurately distinguish between spherocytes and normal cat red blood cells, which is why spherocytes, don't serve as a good marker for IMHA in cats. It's not because they're not actually present, it's because they're so difficult to distinguish between normal red blood cells and spherocytes in cats. We've spoken before about how secondary to any form of anemia, the bone marrow is going to be stimulated to make new red blood cells. Okay, but when you get a severe anemia, and it's particularly the case in IMHA, there is a veritable storm of signaling that goes into the bone marrow that says, make more red cells, make more red cells. So loads and loads of things, protein messengers called cytokines, another hormonal messenger called erythropoietin, and they're all coursing into the bone marrow. And these cytokines in particular, they elicit a rather non-specific response. So they don't just target the erythroid, the red cell precursors, and say, wait, make more red cells. Some of them will also target white blood cell precursors and go, right, make more white cells. And how that manifests in the periphery is, yeah, you'll see a regenerative response because of lots of new red cells, but you're going to see quite a lot of new white cells as well. So you get a leukocytosis, a mega neutrophilia in some instances, and I'm talking a neutrophil count that could be like 6-7 times normal. And a lot of those neutrophils are going to be immature neutrophils, so-called regenerative left shift. The picture you get on the white blood cell front is exactly the same as the picture you would get if a patient had a severe infection. But it doesn't in most instances. It's just a non-specific product of the bone marrow being stimulated. The only way you can tell the difference between a white cell count that indicates infection and a white cell count that is just co-stimulation or a leukoerythroblastic response is by imaging and looking for a source of potential sepsis. Another thing that you will see is you will see not just neutrophils, but lymphocytes being released from the bone marrow at a relatively early stage of development. In other words, these cells can look a little bit like lymphoblasts, which is one of the things you'll see in leukemia. And it's very, very difficult, if not impossible, for a cytologist to make an accurate call sometimes between what's a lymphoblast and what's a reactive lymphocyte. And so sometimes they will simply say there are abnormal lymphocytes in the circulation, okay? And that can cause all sorts of panic because then people start worrying that the patient has an acute leukemia, right? It's incredibly unlikely that a patient with acute leukemia could generate a regenerative red cell response and a regenerative neutrophil response. Their bone marrow should be shot at that point. So again, it's down to us as clinicians to try to make sense from what can sometimes be quite a confusing ClinPath report with these patients. Okay, so that's the diagnosis. And next thing we're going to talk about is treatment. And understandably enough, I think we focus when we talk about treatment for patients with immune-mediated hemolytic anemia, we tend to focus on the anemia for obvious and very important reasons. But I think it's also important to take a bit of a step back and talk a little bit about, right, if we're going to treat this dog or cat with IMHA, in order for our treatment to be tailored to the patient's needs, we have to understand why they're feeling unwell in the first place. Because at the end of the day, isn't that what we're trying to do, make them feel well? And if we don't understand why they're feeling unwell, then we're going to be at something of a struggle to make them feel well again. So these patients will feel unwell because of their anemia. They're not able to get oxygen effectively delivered to their tissues. And how that will manifest will depend on the severity of the anemia. It'll also depend on how quickly the anemia develops. So you will see patients with chronic anemia that look relatively well, even though they have sometimes a very low PCV. And you'll see patients with acute anemia who look considerably worse, even though their PCV is comparable to the patient with chronic anemia. And that's because patient with chronic anemia, their systems have had time to adjust, okay? And they can cope better with an equivalent level of anemia than a patient whose PCV is acutely fallen and whose systems haven't had time to adjust. Now, you can dial down on that as much as you want, and people have, and they've studied how, you know, the red cell behavior changes over time. These red cells in patients with chronic anemia become incredibly good at offloading oxygen to tissues, much better than a red cell in a non-anemic patient. So, and there are other physiological adaptations that patients with chronic anemia go through in order to survive with a relatively low PCV. And the patient with the acute anemia simply has not had any time to make those adjustments, so they will feel worse with an equivalent degree of anemia. The other thing that affects how poorly a patient will feel with their anemia is comorbid states. Now we're going to come on to this again in a little while. But if a dog or a cat has other types of organ failure, or if they have chronic respiratory disease, or if they have chronic cardiac disease, and they're inherently less able to circulate oxygen around their tissues, then they're going to suffer with the effects of anemia at a relatively earlier stage than an otherwise healthy patient. We've said before how some dogs and cats will have an underlying disease that's triggered their anemia, and that underlying disease may also be contributing to their clinical signs of illness. About 30% of dogs with IMHA will suffer from thromboembolic disease. We'll talk about that a little while later as well. But certainly these patients can become acutely unwell due to the effects of blood clot forming. Cytokines, these inflammatory mediators of inflammation. Remember that IMHA and any immune-mediated disease is a very, very inflammatory disease state. So these patients will have lots of cytokines floating around their circulation. And we can sometimes see clinical signs developing as a direct consequence of that inflammation. This is something called systemic inflammatory response syndrome. And these are patients that are pyrexic. They may be hypovolemic because they've got massive vasodilation. They may develop signs of other organ damage as well as a consequence of inflammation targeting heart, brain, kidneys, and so on. Some of the sickest patients I've ever seen are patients with severe immune-mediated disease. And the reason they are so sick very often is that they have variations on this systemic inflammatory response. But this inflammatory response that is part and parcel of their immune-mediated response is very capable of making patients feel really, really sick. And you have all seen it, I guarantee you, because you've probably all in your time here or elsewhere seen dogs that are a third or fourth or fifth red cell transfusion. And they're breaking down their donated cells, they're breaking down their own red cells as well. And they're jaundiced and they're miserable and they look sick to death, some of these dogs. I'm sure you've all seen it. And that's why, okay? But we tend to ignore that because we focus on the anemia and the other stuff that's going on. But that's real and it causes real problems and it can be fatal. So what are the questions then moving on from that that we need to answer when we treat IMHA in dogs and cats? We need to know if our patients need blood transfusions. So we need to be able to recognize when they need us to intervene. We need to understand where there's any underlying disease that's triggered all this off in the first place, and does that need treating? We need to understand, and this is where the difficulty arises, how to suppress these patients' immune systems. And if 30% of dogs and an unknown percentage of cats with IMHA suffer from thromboembolic disease, it would serve us to know how to stop that happening in the first place. So these are the questions that go into how we treat these patients. So the first thing is transfusion therapy, and how do we use blood transfusions to help our patients with IMHA? The key thing to understand is that you're never, ever, ever going to cure a patient with IMHA by giving it blood. It doesn't happen. All we are seeking to achieve with blood is we buy time. We're buying time for the medication to work. That's all we're doing. That's the absolute best thing we're going to achieve. But that is all we are going to achieve with blood transfusions. Just buys time. Papers over the cracks, buys us the days that it needs for the medications to start to work. The time red blood cell transfusions will buy us, however, is short. In most patients with IMHA, it's days. In some patients, it's hours. Or in some patients, they simply destroy the red cells we give them so quickly it is of no benefit at all. Worst case scenario. So, if you have a patient with anemia for some other reason, then the red cell transfusion could last a long time, potentially weeks, okay? But for us, for our patients at IMHA, very, very short-lived, all right? Because it's so short-lived then, we need to be real good at identifying the patients that need it, okay? And giving it when it's needed. We also need to be aware, I know you are, because of Ariane's lecture a few weeks ago about the necessity for blood typing. I'm not going to go back into that again. It's to say that blood typing prior to any transfusion is essential in cats if you're giving feline blood. It's useful in dogs even prior to a first transfusion, but it's essential if you're following up with multiple transfusions in a dog that's previously received blood. So when do we transfuse dogs? Well, first thing to consider is if we're transfusing patients as a life-saving intervention, and it is always going to be a life-saving intervention if we're using it correctly, then we need to understand why dogs die of anemia. So they die because their organs fail as a consequence of a failure of adequate delivery of oxygen, because they've got no red cells and no hemoglobin to carry the oxygen.
For reception, for waiting.
So, and the organs that are usually targeted are brain, heart, sometimes other organs as well. Generally speaking, if anemia is going to kill a patient, it's because their brain shuts down or they have a fatal arrhythmia. So what determines whether anemia is going to kill a patient or not? Well, clearly, I guess severity of the anemia is going to help, is going to be important. So the more severely anemic these patients are, the greater the risk they are dying of the anemia. That's common sense. But there are other things as well that have an equally important effect in determining whether our patients are going to have life-threatening complications as a consequence of the anemia. Another thing that can affect this is how effectively these patients get oxygen onto the red cell hemoglobin. And that really depends on how their lungs are working. It also depends on how functional their hemoglobin is, but in the vast majority of patients, their hemoglobin is absolutely fine. So if you have two dogs, both of them have a PCV of 20, and one is a Frenchie and one is a Dachshund, which do you think is going to suffer the most? And you stress them out. Who's going to suffer blue first? Yeah. In fact, neither of them are going to turn blue because they're anemic. They won't have enough red cells to be cyanotic. But one of them is going to start gasping first for sure. And it's not going to be the Dachshund. Okay? We all know this, but the key thing is that the Frenchie is probably going to struggle more to ventilate and get oxygen onto its red cells and into its hemoglobin. It's going to struggle to do that more than the Dachshund. So respiratory disease, lung function, that has an important determining effect on how ill this patient is going to be with any degree of anemia. Equally, our Doberman with dilated cardiomyopathy is probably going to suffer the effects of anemia more than our Labrador with a perfectly healthy heart because its circulation is impaired. Or our Cavy that's squirting about 30% of its stroke volume through its dysfunctional mitral valves. Its circulation isn't going to be that great either. And so its ability to get that oxygen around to its tissues is going to be less than that of a dog with a healthy heart. We know that many dogs with IMHA will have signs of pancreatitis. We've already said how lots of dogs with IMHA have other diseases that may be damaging other tissues. And those tissues that are already damaged require oxygen to repair and therefore are going to be more susceptible to the effects of anemia than otherwise healthy tissues. So the key point is this, that and the degree of anemia is only one of about 4 things that governs how unwell our dog or our cat with anemia is actually going to be and what it's going to look like. And because of that, there is no absolute number in terms of PCV or red cell count below which it's absolutely necessary to treat or above which it's absolutely safe not to transfuse. So red cell count by itself does not serve as a transfusion trigger. It can't, because as we just said, it's only one of about 4 things that governs how clinically ill our anemic patients are going to be. That said, there are studies on pathological studies which have shown that once the red cell count drops below 20, there is thereafter an almost linear association between the severity of the anemia and the amount of necrosis or damage in various internal organs. Okay, but that, as I said, because there are so many other variables, that is not an absolute cutoff. There are some animals, however, that are in a situation. So, and because of that, we tend to look not just on the red cell numbers, but we look to see, are these patients showing other clinical signs of anemia? And we use that to gauge when we intervene with a transfusion. I remember when I was an intern at Dublin, this was last century, I was, and I went to the American College of Veterinary Internal Medicine annual congress, and it was just blew my socks off. There was all these amazing people talking about amazing stuff, and I was at a lecture. Oh, it wasn't a lecture; it was an abstract series on transfusion medicine. And there was some luminary, I forget his name, he's talking about transfusion, presenting results of some research. And it was research using a thing called oxyglobin, that is a purified bovine hemoglobin that we no longer have, but it was really good at the time. And I remember asking him, oh, how did you know when the transfusion had worked? And he looked at me like I was something on the end of his shoe, and he just went, well, it was lying down. I gave it the oxyglobin. When I got up and walked, that's how I knew it had worked. And I thought, okay, fair enough. I was expecting to hear, well, we put it through a gamma camera, or we did all sorts of amazing stuff, and that's how we figured out. We just said what he was telling me was, well, it's clinical science. It was collapsed, clearly needed a transfusion. Gave it the oxyglobin, and then I knew it had given it enough when it got up and walked. And that is still the status quo. That's how we gauge whether a dog or a cat needs a transfusion, and how we judge whether we've given enough. And it's that more than the red cell count that counts. Okay. Also, we know our patients. We know what else, hopefully, is going on or not going on. And so we should be able to identify the patients that are perhaps going to run into problems through lack of enough red cells at an earlier stage than others. These are the patients with respiratory disease. These are the patients with cardiac disease. These are the patients with other organ damage, all of whom may start to suffer the effects of anemia at an earlier stage or a higher red cell count than otherwise healthy patients. Now, I'm not saying that we disregard the red cell count, but I am saying that we very rarely do we interpret it as a transfusion trigger by itself. There's one group of animals where we do have to look at the red cell count and put perhaps more significance on that than we would otherwise. And these are patients where they cannot show other signs of transfusion dependency. They cannot become tachycardic. They cannot become weak. They cannot go off their food or show other signs of worsening anemia. And these are patients who are under anesthesia. So they cannot really reliably show other signs of anemia. So for those, and dogs in particular, yes, I think sometimes we do have to look at the red cell count as being a transfusion trigger. And for those, maybe I would suggest a red cell count in excess of 20, or 20 PCV in excess of 20% for dogs. But again, we need to factor in other things as well. How long has it been anemic? How quickly is that developed? Does it have other signs of organ failure? How long is the anesthetic likely to be? Do we anticipate blood loss? So there are other things that factor into that decision as well for our anesthetized patients and those undergoing surgery. So the other thing to consider is there evidence of secondary disease or some underlying disease that's triggered the IMHA? And these are the things that we look for. Our history should tell us if there's been any drug or toxin exposure. Our history will also tell us as whether it's likely that a patient has picked up any infection. Is there a history of travel outside the UK? Is there a history of tick exposure? We may also look at urine cultures, blood cultures if we suspect that there is some underlying sepsis. We may also look at retroviral testing in cats, and in those cats that have likely been exposed, then testing for mycoplasma. In dogs that have been exposed to ticks, then we may want to test for Ehrlichia and other rickettsial diseases, or Babesia if there's a history of travel outside the UK. And imaging may also be necessary, looking for underlying infection, inflammation, or neoplasia that may have triggered IMHA. And if we do find any lesions on our imaging, then taking samples may also be important to achieve a diagnosis. There is good arguments to be made for doing that in our patients, because establishing whether there is an underlying trigger factor is important for two main reasons. One, if you identify and treat it, then the immune-mediated disease that's arisen as a consequence is much easier to control. And secondly, it's got prognostic significance as well. So if it's IMHA, it's also riddled with cancer, then the prognosis is obviously much worse than if it's IMHA alone. But there is also, the counter argument is that all of this costs a considerable chunk of money to do. And we're fortunate here in that a lot of our patients are insured, or our clients are sufficiently heavily invested in the patient that they are willing to fork out hundreds or thousands of pounds that are necessary to do all these tests. But outside of the rarefied air of a referral hospital, then frequently that's just not possible. You know, and we've all been there in first opinion practice, all had clients bringing in animals. They've got about 50 quid, which is about, 3 times what the animal's PCD is. They may have enough money for an external hematology or a Coombs test, but that is it. No more, no way. And it's fine to adopt a much more pragmatic approach. I mean, is that dog that's lived all its life either in its owner's handbag or in the back garden likely to have tick-borne disease? Particularly, how easy is it going to, particularly as, it's never been within 100 miles of a tick in its life. So how likely is that to have anaplasma or babesia or some other rickettsial infection? Is it really worthwhile spending 180 quid to test? Equally, if we don't have enough money for imaging, then it's fine to adopt a somewhat fatalistic approach. Okay, it may have cancer, but we don't know. It's still fine to treat the IMHA so long as the owner is aware that the response may not be as good as we could hope for. But that's fine. So it is possible to treat these guys on much more of a shoestring than perhaps we sometimes adopt here. But it's not, and what I'm not putting an argument for is that we shouldn't do this testing, but I'm saying that in the real world, there are plenty of instances when that testing is simply not possible. And there's absolutely no point spending hundreds of pounds doing x-rays and ultrasounds and PCRs and all of that happy stuff when at the end of the day, you've got no money to actually treat the patient. So next thing is what immunosuppressive therapy to use. So we talked about transfusions, talked about looking for underlying triggers. Now how are we actually going to switch this aberrant immune response off? And this is where it falls apart a little bit, because this is where the evidence is lacking. So we know that glucocorticoids are probably the most effective drug at our disposal, or we think so, because nobody really has ever tried managing a dog or a cat with IMHA without steroids. It's kind of similar to trying to manage a dog or a cat with heart failure without furosemide. You could, but you're going to have to go some to get clients to sign up to that sort of experimental trial. Cyclophosphamide is apparently really, really bad for treating dogs with IMHA, because all of the dogs, or a lot of the dogs that got cyclophosphamide, died of their IMHA. And okay, that's fine, until you actually start reading these papers. And you realize that all of the papers that looked at cyclophosphamide are retrospective studies. Okay, so basically what researchers were doing, they looked at every dog that had been treated in their institution over the last 5 years. Okay, and they're trying to work out which drugs worked and which drugs didn't work. Now, the problem with that is that the sicker a dog is with IMHA, the more likely it is to die, right? The sicker a dog is with IMHA, the more drugs it tends to be given at the outset, okay? Because they go, oh my God, it's really sick, let's just give it everything. And it dies. You go, oh, that's very sad. But the problem is that every single dog, the ones that got better and the ones that died, got prednisolone. But it's dogs where people went, it's really sick, give it lots of drugs. Those are the dogs that got cyclophosphamide, and they all died. So were they dying because they got cyclophosphamide, or were they dying because they were really sick to begin with? And that's the problem with retrospective studies. Okay, there is something called treatment bias. People are more inclined to give lots of drugs to sick patients rather than to the relatively healthy ones. So we don't actually know if cyclophosphamide is bad for dogs with IMHA. Interestingly, chlorambucil is used really frequently in cats with IMHA and seems to work quite well. Same class of drug. Why should it work better in one species than another? So, our guess is initial therapy, In dogs, steroids, because we don't dare not use steroids. Something else for the really sick patients? No evidence to guide us one way or the other. Azathioprine, traditionally used. But the problem with azathioprine is it takes about 2 to 3 weeks to work. And that's not really ideal if you want a drug that, if you got a really sick patient, you want something that's going to work quite quickly. So mycophenolate and cyclosporin still take a week or so to work, but may work slightly quicker. We probably want to use something to stop blood clots forming. Remember, about 30% of dogs will get blood clots forming as a consequence of IMHA. So maybe aspirin or clopidogrel. In cats, don't use azathioprine. Never use azathioprine in cats, because cats lack an enzyme called thiopurine methyltransferase, or TPMT. If you or I is going to get azathioprine for some reason, our concentrations of TPMT will be measured, because that enzyme converts azathioprine to less toxic forms, okay? And our dose will be calculated based on our levels of TPMT. Cats do not have TPMT at all, none, nothing. So that means that even a small amount of azathioprine can cause quite severe toxicity to cats, tends to shut down their bone marrow, which isn't really ideal when you've got anemia, face it. Okay, so don't use azathioprine. Chlorambucil does seem to be quite effective.
Just to let Shona know, Luna is here for the reaching appointment.
And whether we should be using clopidogrel instead of aspirin for cats, because clopidogrel is seemingly more effective for cats that are predisposed to a different form of thromboembolic disease. These are cats with aortic thromboembolism secondary to heart disease. Maybe the same applies for IMHA. We don't really know. So prednisolone is the one drug for which we seem to be broadly in agreement that is the mainstay of treatment for cats and dogs with IMHA. It is also the one drug to which we absolutely predict that side effects are going to occur. It's the only drug basically in veterinary medicine that we use where you can say at the outset, I can hands-on guarantee your dog or cat is going to suffer side effects of this. You know, everything else we say, oh, side effect could happen, but hopefully they won't, and yada, 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 and prednisolone at immune suppressive doses, yeah, you're going to see side effects. It's just give it. So owners need to be aware from the outset that this is to be expected. And that's really important at point of discharge. I know we've got the steroid handout. That really should be going with every animal that's on an immunosuppressive dose of prednisolone. And for the owners who will just not bother to read it, it should be pointed out to them as well. It's going to be PUPD. It's going to be polyphagic, okay? Also, and don't be afraid to individualize the dose. So, you know, if you took 10 dogs with the same body weight and gave them the same dose of prednisolone, you're going to see 10 different manifestations of severity of side effect. So dogs are individuals. And so some dogs we will need to back off the prednisolone dose faster than we would for other dogs. So as soon as you start using steroids, you're walking a tightrope between controlling the disease on the one hand and side effects on the other hand. And we need to get the dose right for every individual rather than simply applying a fixed protocol and a fixed dose, okay? And so it's important to try to do that as we go on through treatment. For dogs that are, for larger dogs, and you probably all know that, you know, big dogs sometimes be much more prone to severe side effects of immunosuppressive dose of steroids as opposed to smaller dogs. And there is a school of thought that says we should be dosing larger dogs on body surface area rather than a mg per kg basis. Because actually, if you look at dosing on body surface area, the amount of drug you'll use, the amount of prednisolone you prescribe for those dogs over 25 kilos, ends up being considerably less than what you'd use on a 2 mg per kg basis. Okay. Now, we don't know if that translates to a more effective treatment. For sure, it's going to translate to less severe side effects. So, well, I'm going to park that for there, but I do sometimes, and particularly if a dog I feel is going to be more prone to the side effects of steroids, if it's a big dog, go for a meter squared dose rather than a mg per kg dose. Once daily dosing seems to be as effective as twice daily dosing, and only requires the owners to only recall once a day that their dog's on some medication rather than having to do it twice a day. And for those dogs that are intolerant, or cats that are intolerant of steroids, of oral steroids, then we can use dexamethasone parenterally, at least initially. When is that not going to be enough? When do we need to add another drug? Well, there are some markers of disease severity that we can use. Yeah. Hi, it's Rory. I'm in the middle of a lecture at the moment. Is there? Okay, if you can send me a task, I'll put the medication up at the end. Thanks. Okay. So yeah, when do we add another drug? So some markers of disease severity, so the dogs with very severe anemia, very rapid onset of anemia, those dogs that have red plasma, or very, very jaundiced, where we suspect maybe more intravascular hemolysis. We know that dogs that have severe hyperbilirubinemia and those dogs that have increased blood urea nitrogen at point of admission tend to have a worse prognosis. So they're sort of prognostic markers that we can apply to say, well, maybe we need to be a bit more aggressive in our treatment of these dogs. If we feel that the side effects of steroids are going to be severe for whatever reason, so say this is a really arthritic dog, okay, and it's got really poor muscling, and we think, okay, we give this dog a steroid myopathy, so steroids can weaken muscles, it's just going to go off its legs entirely, so we're going to need to back off the steroids quite quickly. Then adding in another drug will be useful because these drugs then have a steroid sparing effect. And that, I mean, they allow us to withdraw the steroids while having a greater degree of control over the underlying immune disease. And obviously, if there's a failure to respond to steroids. In terms of the drugs that we can use, azathioprine, again, it's got quite a long time to effect. So mycophenolate and cyclosporin we tend to increasingly use because they're perceived to have a shorter duration to response. The other advantage of mycophenolate is we can give it IV to those patients who aren't tolerant of oral meds. So next thing to consider is what drugs are we going to use to stop this dog or cat throwing clots. We don't fully understand why 30% of dogs with IMHA will get thromboembolic disease. There's lots of studies that have been shown that have been done in this, and these dogs tend to have platelets that are activated and more prone to form clots. They do have activation of their coagulation cascade, and these are a series of proteins that together turn fibrinogen into fibrin, which forms a clot. Now, interestingly, the majority of thrombi in dogs with IMHA are in their veins rather than their arteries. Now, this is important because clots that form in the veins tend to be as a consequence of activation of the clotting cascade, so they're full of fibrin. Clots that form in the arteries tend to be as a consequence of activation of platelets, so they're full of platelets. Okay. There is a study that some of you may have come across called the fat cat study. Okay, and this was looking at cats that have aortic thromboembolism. So by definition, thrombi that are forming in the arteries that are rich in platelets. And in these cats, they were forming as a consequence of heart disease. That's the most common reason for cats to get thrombi. And it's in their arterial system. And we know that clopidogrel, to a lesser extent aspirin, are helpful at stopping this happening. But remember, our dogs, and presumably our cats, so it seems to be less common in cats, with IMHA, that get clots, they are not arterial. They are not rich in platelets. They are venous and they are rich in and they are rich in fibrin. So the underlying mechanism behind this clot formation is different. And the drugs that we would be best placed using to prevent fibrin-rich clots forming are different to the drugs that we use to prevent platelet-rich blood or clots forming. So clopidogrel and aspirin both work by inhibiting platelets, and that's fine if you're getting at risk of getting an aortic thromboembolus. For our dogs and cats with IMHA, using where they're at risk of getting fibrin-rich clots, using drugs that are inactivating platelets doesn't seem to make much sense. So maybe these drugs that we use are not the right drugs. Now, in terms of when we use them, almost every single patient with IMHA will end up on with some form of antithrombotic prophylaxis. And in light of what I was just saying, then there's very limited use or evidence, but some evidence that low-dose aspirin is of help in dogs with IMHA. But it's useful to point out that in this paper that was published in 2005, so some time ago, aspirin did not prevent thromboembolic disease in all patients. Some of the dogs that were treated with aspirin still developed thromboembolic disease. If we are using aspirin, then using the soluble tablets can really help dosing, because otherwise these are 75 or 300 milligram tablets. It's really hard to break them down to sufficiently small sizes to enable efficient dosing in most dogs. And in terms of looking at drugs that are perhaps more effective than aspirin or clopidogrel for treating venous and fibrin-rich thrombi, then heparin may be useful, but heparin is only given by injection, so it's a bit of a faff and not really something that's convenient for long-term use at home. Rivaroxaban is a relatively new drug that targets factor 10, which is part of the clotting cascade. We have only just begun to use it for dogs that have or are at risk of getting thrombi, so there is no clinical evidence at present to suggest that it's going to be useful, but that's the way the future may be looking. Okay, so we've started our treatment in our dog with IMHA. We're 3 days in, nothing's happening. ECV is still dropping, it's on its second transfusion. And the key thing here is that we're still working within the window of opportunity for the drugs to have an effect. So we need to buy time. That's all we can do. Buy time and wait. And I think it's really useful. I mean, in terms of client communications, very often I'll phone up a client and say, well, yeah, your dog's been anemic. We know what's wrong. It's got IMHA and we started treatment. Like, oh, brilliant, that's fantastic. No. This is now, we've got the diagnosis, we've got a treatment, but it takes days for the treatment to start to kick in, sometimes a week, sometimes longer. And I think it's quite worthwhile saying to them at that point, this is now a waiting game. And this is going to be real stressful because we're going to be on the phone, you're going to be on the phone to us every day, and we're going to be, it's the same. We've got to wait. It's the same. Or it's gone down and now he needs blood transfusion. And you're going to think the medications aren't working, but it's a question of giving it time. And nothing's going to work in hours or a day or 2 days or 3 days. It's going to be longer than that. But I think it's real helpful if they're in that loop from the get-go. They know that it's going to be time, because it's natural for people to be impatient. It's natural to think, well, you've got a diagnosis and you've got a treatment, so surely it's now a day or so and it's going to be fine. It's not. It takes a while. It'll take 5 days really before we're going to see the full effect of prednisolone, and it'll take considerably longer for us to see the effects of any other drug we're using, even the relatively fast-acting ones like cyclosporin or mycophenolate. So if we're using prednisolone by itself and we're seeing a fairly stable or a slow decline in hematocrit, then it's probably fine to give it the 5 days before we add in another drug. If, however, there's more rapid decline in the hematocrit by 5% or more, and especially if the dog's showing signs of requiring a transfusion, then obviously we're going to step in with another drug as well. The then 2 questions at that point are, right, if we're going to step in with another drug, what are we going to use and when are we going to use it? So assuming we're using prednisolone by itself, then another drug, we're going to use that if there's no response within about 5 to 7 days, despite the dog having a regenerative anemia. I'm going to use it. I'll use another drug if there's a more rapid decline in PCV in the interim by more than 5%. With what? Cyclosporin, leflunomide, mycophenolate, intravenous immunoglobulin. Usually it's a combination of either cyclosporin or mycophenolate initially. Intravenous immunoglobulin we used to use a lot, but now it's no longer widely available. And the reason we use intravenous immunoglobulin is because it worked really quickly. There is a case series of dogs with IMHA that was refractory to medication. About 5 of them, they all had their spleens out, and they all did better. Is that an argument to be made for using splenectomy as an adjuvant treatment for IMHA? Probably not, but there may be some dogs that can benefit. The key issue here is that we're in territory here where there is no evidence whatsoever to guide our clinical decision making. And this is kind of where it's every person for themselves in terms of, picking a therapeutic regime, but we don't really have any evidence to suggest what to do or when to do it. Intravenous immunoglobulin, as I said, no longer widely available now, but it used to be, and it may be again in the future. So I'm just going to mention it here. Do you remember we said when we look back at how IMHA worked to kill red cells, it all revolved around the generation of anti-red cell antibodies that bound onto the red cells. And then in some instances, that antibody was targeted by macrophages. If you give immunoglobulin, then effectively what that does is it stops the interaction between the antibody in the red cell and the antibody red cell complex in the macrophage. So it stops that immune system dead in its tracks. So it works very, very quickly. It is a foreign protein, and you can have allergic reactions when you use it. It is also expensive. I mean, when it was available, it was about somewhere, depending on the size of the dog, anywhere between £200 to £900 a dose. So you tend to only to use it once. And the other reason for only using it once is because it was a foreign protein. If you gave it repeatedly, you're pretty much certain to end up with some kind of allergic reaction. Nowadays, no longer available, but maybe back in the market in the future. Okay, so we've got our dog or a cat, and it's in remission, and we now got to decide how we're going to taper the medication, how long we're going to give the medication for, how we're going to monitor this patient's condition. And this is a table that was included in the BSAVA formulary around 2009, 2010, and subsequent iterations of that table have been in every formulary since. And this is designed to show how to treat a patient with IMHA from the point they're in remission until you successfully wean them off all medications, which is great. There's one slight problem with that table, and that is that the person who put it together didn't have a clue, didn't know, because they didn't have any evidence base what they were doing. They were just had to come up with some way of treating IMHA and having a default protocol that everybody else in the institution could follow. But that person scrapped around the papers and looked to see what the evidence base was, decided there was absolutely nothing, so they had to just do it, sort of back of an envelope style. And that was fine. And then the protocol got nicked by a professor who was working with that person, who that professor was editor of the formulary, and he stuck it in the formulary. And now it's standard of care. And I know that the person who drew that hadn't a fucking clue, because I was the person who made that protocol. And I did it because there were loads of people. I was head of medicine at Glasgow. There were loads of people coming in, and one person came in to rounds one morning and said, I saw John Doe's case of IMHA, and it was on a drug called can't remember the name, don't know what it does, so I stopped it. And I thought, this cannot continue. So we came up with that protocol off the back of no evidence whatsoever simply designed, the aim was that I wanted to have a default means of treating dogs with IMHA that we could then audit to see actually how effective it was. But then it got nicked and then it ended up in the BSA formally. And it's just a classic example of how something for which there is no evidence whatsoever gets out into the mainstream and then becomes just accepted without question as being, this is how we do it. It's the same as that you've probably seen it. There's a graph about how to supplement potassium in a drip. Fuck, it doesn't, there is no evidence for that whatsoever. That was going to be like some intern came up to some professor and said, oh, could you tell me how much potassium to put in the drip? Professor probably wrote down a set of instructions on the back of an envelope, handed it to an intern, who then 20 years later is a professor authoring a textbook and stuck it in. And then suddenly everybody thinks that's gospel, but it isn't when you think about it. It takes into no account whatsoever how fast potassium is being lost by a particular patient, what underlying pathomechanism there is for the hypokalemia in the first place, or even why you're trying to supplement. So yeah, hang on. I'll stop that, okay? But I did that about 20 years ago, well, 12 years, sorry. And looking at now, if I was to do that again tomorrow, based on my experience over the last 12 years, I think that would look very different, or there would be some differences. Again, this is not good evidence. One person saying, oh, this is my anecdotal evidence, that's the weakest form of evidence that there is, but it's pretty much all we got to go on. So here goes. That glucocorticoid dose is being reduced far too quickly. In my book, I would not run it out for 2 months beyond remission. It'd be more like 4 months. And I would step it down at 20 to 25% increments, not 50% at 2 week or 3 week intervals. Remember what I said, however, about striking a balance between the severity of signs of glucocorticoid excess and the need to retain remission on the IMHA. So it has to be a balance. But generally speaking, I would treat for longer. I would drop the dose by smaller increments at each time. I would not use azathioprine. I would use mycophenolate or cyclosporin. I think running that out for 2 or 3 months is probably fine. I don't use gastrointestinal protectants in patients with IMHA, not unless they're vomiting blood. That was there because we thought that high doses of steroid were ulcerogenic. They're probably not, and even if they do, they're going to cause ulcers through means that are completely different to what we're treating with anti-ulcer drugs like sucralfate or omeprazole. Something else that clients will often want to talk to us about, or referring vets will want to talk to us about, is we've got a dog, and this is any type of immune-mediated disease, right? Not just IMHA. Right, we've got the dog, it's our cat, we've treated it, it's in remission. What about vaccination? So, you know, and the problem with vaccination is that it's the only drug that we give or medication that we give that works by stimulating the immune system. And these dogs and cats have shown us that they have an immune system that is prepared and equipped to go off on a tangent and start attacking its body's own tissues once it's stimulated. So vaccinating these dogs and stimulating their immune system inherently carries with it a higher degree of risk than vaccination for an otherwise healthy dog or cat. However, there is certainly no evidence to say that for a population of dogs or cats, vaccination causes immune-mediated disease. It doesn't. But there are some individuals who are those individuals probably who previously had immune-mediated disease, where repeatedly vaccinating them may carry with it an element of risk. Now, we have looked at dogs with immune-mediated thrombocytopenia, and we are looking at long-term follow-up of these dogs for entirely different reasons. But we also followed them up, and one of the things we questioned owners about was, did you, at any point after your dog was diagnosed with immune-mediated thrombocytopenia, have your dog vaccinated? And a few of them, and this was of a cohort of pretty much over 100 dogs, the IMT, about, I think, 13 or 15 had recurrent vaccinations. None of them had a relapse. Now, the numbers are very low, okay, and that's not to say that we can, give vaccines to dogs with previous histories of immune-mediated disease and not have any problems. But I do think there are, the risk of repeatedly vaccinating a dog that has previously been diagnosed with immune-mediated disease is probably quite low, although there is a risk, albeit low, of that vaccine causing a relapse of immune-mediated disease. And it's interesting when you talk to clinicians who work in referral hospitals, and you talk to clinicians who are primary care practitioners about their attitudes to vaccinating dogs with immune-mediated disease. The referral clinicians generally go, no, don't vaccinate them ever again. Yeah, that's fine, but you, Mr. Referral Clinician, you don't tend to see dogs with parvo very often. You don't see dogs with lepto. Whereas the primary care clinicians presumably do, and are less sold on the idea of no vaccine evermore. I think there's a middle of the road, and it comes down to an individual risk assessment. So if you are the owner of a terrier who from Monday to Friday runs around with packs of other dogs through woodland and farmland, Saturdays and Sundays goes ratting, then yeah, you should probably get that dog vaccinated. If you're the owner of a purebred terrier who goes to shows and is thereby mixing with lots of other dogs, or if you're the owner of a dog that is going across to the EU and needs to be vaccinated against rabies as a legal requirement, then yeah, the risks of vaccination are probably outweighed by the risks of not vaccinating. If you're the owner of that Bichon that we saw a photograph of a few slides back, that spends its entire day on its owner's couch or in the walled-off back garden, never mixes any other dogs, has minimal chance of coming into contact with any form of vaccinal disease, then probably the risks of vaccinating are probably too high, because the risks of it coming into contact with any vaccinal disease are so small. So it's a risk-benefit analysis that should be performed on an individual. And yes, we can run serology. It costs a lot more than vaccinating the dog, but we can run serology to gauge the level of immunity to diseases other than leptospirosis and kennel cough. So in terms of prognosis, about 50 to 80% survival in dogs with 11 to 15% relapse, 70 to 80% survival in cats with, for reasons I don't understand, I think a higher rate of relapse. What I think is probably behind this number are the cats with retroviral infections with FIV and FVLB who have relapses because they have an underlying disease that's affecting their immune system. The difference here, we've got 70 to 80% survival versus a much wider range here, 50 to 80% in dogs. And the reason for this number is in North America and the North American Cocker Spaniel. And North American Cocker Spaniels are genetically hardwired not just to develop IMHA, but to develop a really nasty form of IMHA. These are the dogs that get intravascular hemolysis. And if you look at the papers on IMHA survival that come out of North America, then two things are immediately apparent. One, the vast majority of the dogs they see are North American Cocker Spaniels. Secondly, they all have a really nasty intravascular hemolysis that Cocker Spaniels on this side of the Atlantic and in other parts of the world do not get, or certainly don't get as frequently. So there is a genetic predilection that Cocker Spaniels in North America have to getting not just IMHA, but a really bad form of IMHA, and that skews the survival. Again, often worthwhile mentioning to some owners who go off on Google, and in between you making the diagnosis and then the subsequent conversation, I've come across a slew of internet sites that all say their dog's got 1 in 2 chance of dying. And then pointing out to them that a lot of the times that's a different population of dogs to what we see here. Some dogs will develop non-regenerative IMHA. It's otherwise known as pure red cell aplasia. Now, this is These are dogs where the immune system isn't targeting mature red cells in the circulation. Instead, it's going off and targeting cells in the bone marrow. So the bone marrow is effectively switched off. It's not producing any new red cells at all. These dogs will be persistently non-regenerative because the target of the immune response is within the bone marrow, not in the circulation. These dogs may not have spherocytes. They may not be Coombs positive. They may have no signs of immune response against the red cells in the peripheral circulation. So these are dogs where we need to do a bone marrow sample, aspirate and a core biopsy to exclude other diseases like myelofibrosis, myelodysplasia, subleukemic leukemia. And typically what you're going to see in these dogs is usually what happens is the red cells mature up to normoblast stage, so quite late on in the maturation process, and then it just stops. There's nothing beyond that. And occasionally it'll be reported that there is increased plasma cells or macrophages within the bone marrow, where you shouldn't see plasma cells or macrophages. They don't go in there, they shouldn't be in there, which would signify that there may be an immune response. But the signs that you see are typically quite, on a bone marrow histology are quite subtle and non-specific. Principally, you're using that bone marrow sample to rule out other things that could cause a non-regenerative anemia. And then because very often in these dogs, we don't have proof positive that there is an immune response directed against precursor cells, we've just got to treat and hope. And we said before about watching and waiting for the other types of IMHA, even more so with non-regenerative IMHA, because the time to response is much, much longer. So over a month before we see a 5% increase in hematocrit in dogs, 120 days to remission in one report, and in cats up to 6 weeks before we see a response. So that's a lot of treatment and a long time before we see a response. And the reason being is that in these dogs and cats, two things have to happen. Remember, for the dogs with IMHA that's directed against mature red cells in the circulation, the bone marrow oftentimes is already working. So as soon as you switch off the immune response, boom, red cell count goes up. In these guys where the immune response is targeting the bone marrow cells, you've got to stop the immune response, and then you got to wait for the bone marrow to recover and repopulate. So it takes a lot longer. So time to response, even if you're going to see a response, and in most cases you do, takes a lot longer. Other treatments that we can use for IMHA, things like lithium, which there is no evidence base. What it can do, however, is lithium can cause a worsening PUPD, which is important because these animals will also be on steroids. Anabolic steroids have been trialed, but no evidence of benefit. But iron supplementation is important, and iron supplementation is something we need to be aware about in the long-term follow-up of dogs with any form of IMHA. Because remember, dogs and cats, particularly cats, do not have very good stores of iron at all. And these dogs and cats that have an increased demand for new red cells need more iron to make hemoglobin. If they don't have it, they're not going to make any new hemoglobin. Without any new hemoglobin, there will be no new red cells. So in the follow-up, we're not just looking at absolute red cell counts. We're looking to see, is the diameter of the red cells decreasing? So these cells becoming microcytic. Is the hemoglobin content of these red cells decreasing? Are they becoming hypochromic? And these are going to be the early signs of iron depletion. So some dogs and cats will require iron supplementation. Don't know if many of you remember a Cocker Spaniel called Nellie Weatherall. She was in with us for some time. You spoke to her owners, Lauren, 2 days ago or something. You did. She had immune-mediated thrombocytopenia and really severe GI hemorrhage, and we think she had immune-mediated hemolytic anemia as well. She responded well initially, and then her red cell count went up to sort of 15, 18, and then it plateaued, and she became microcytic and hypochromic. And then we started iron supplementation, and in last bloods from her own vets, her anemia had completely resolved. So it's just important to bear in mind that these dogs and cats are at risk of becoming iron deplete or iron deficient, and some of them will require supplementation with iron. Okay, so this isn't going to be as long as IMHA, don't worry. We're now going to talk about immune-mediated thrombocytopenia. And this is a disease, again, that affects young to middle-aged dogs and cats, although it is incredibly rare in cats. So most of this pertains to dogs. We're looking at Cocker Spaniels, Old English Sheepdogs and Poodles as being predisposed. And pathophysiology, it's very, very similar to what we described about for IMHA, where we get our plasma cells that are autoreactive, producing antibodies that in this case aren't targeting red cells, they're targeting platelets. And as a consequence of that, macrophages and other cells of the immune system are destroying the platelets, and we get very often a very, very severe thrombocytopenia. So